Hello Ryan, I'm Barry McGrath. Thanks for coming today for this case-based discussion. From the notes you provided, I've selected Mrs. NP. So would you firstly tell me why you chose this patient for our discussion today?
So Mrs. NP is an 87-year-old lady who presented with, she was actually acute, very emotional at that time, with chest pains and signs and symptoms of biventricular failure with rapid palpitations. It turned out that she actually had atrial fibrillation at that time, and what was interesting was her preceding history where she had significant heart disease for many years, and she also had a brief hospital admission for the same problem, and her management was actually quite challenging to me, but that was a good learning opportunity.
Well, let's focus on the history. You've indicated in your notes here that she's been unwell for many weeks. Could you tell me a bit more about the time sequence of her symptoms?
Yeah, so first of all, she had a long history of hypertension, which was quite difficult to control. She's been seeing her GP and a specialist regularly for this, and her palpitations were first documented in 2008. And if you look into my notes, she had her ECG back in 2009, and she had abnormal ectopics at that time and abnormal conduction as well. There was also leg swelling and shortness of breath on mild exertion some weeks, and had a hospital admission with an acute episode of palpitations and worsening of her shortness of breath a month ago, but this was actually not due to ischemia. Her BP was very high since.
So what did you make of the chest pain at the presentation?
So I thought this was cardiac in origin, and this would be related to the stress and the rapid atrial fibrillation.
Okay. You've documented a number of other active problems. If we take the first one, the sort of hypothyroidism, do you think this could have been contributing to her presentation?
Well, yes. If she's been taking more of her thyroxine tablets, that is possible. But looking back at her TSH levels, and that was actually normal 6 months ago.
In your notes, you haven't mentioned much in the way of past history or history of cardiovascular risk factors. Would you like to, particularly diabetes, would you like to tell me a bit about that?
She didn't have any history of diabetes. She wasn't a smoker, and she didn't have any family history of premature cardiac disease.
All right, well now let's turn to your physical examination findings, which you've documented here. What do you think were the most important physical examination findings?
So with my physical examination, it showed that she was in atrial fibrillation with rapid ventricular response, and she also had signs of biventricular failure.
Well, why do you think she had all this edema, so much edema?
Well, I suspect she's been in heart failure for a long time.
You found here some small lymph nodes in the posterior triangle of the neck. What significance did you put on those?
I thought they were in within normal limits.
Well, let's now look at your assessment formulation, this sort of brief statement here. AF with chest pain, query coronary ischemia and CCF. What was the differential diagnosis for a chest pain?
Not really. I thought she was on Nexium for her reflux, but I didn't think that this was related to her reflux. So.
Okay. All right. Let's turn to the management plan here and Could you tell me a bit about your clinical reasoning behind that management plan?
Yes. So I wanted to actually control her heart rate, so I've increased her metoprolol, and I've discussed this case with the cardiology registrar, and he did agree that this patient needs to be admitted under the coronary care unit, and he also suggested to cease her calcium channel blocker. I proceeded to request some blood tests, which is the troponins and renal function test as well, including her thyroid function, and also requested a chest X-ray, and I thought that at some stage she might need some echocardiogram. The other thing that needs to be considered was to start her on anticoagulation, but that can wait till the cardiology team has reviewed her.
Okay, what about the management of the chest pain?
I thought the pain would settle down once the rate has actually settled.
And her heart failure?
I just wanted to send her to CCU, and I think that would be taken care of in that once she gets there.
Okay. Let's turn now to the next time you saw her, which was in the coronary care unit. 3 hours later, I think, when you were on call. Could you tell me a bit about your assessment at that time?
Yeah, so when I saw her her rates actually was has settled down, and she was asymptomatic, meaning no chest pains at all, and her troponins were normal. I wanted to chase the pending other blood tests and liaise with the cardiology registrar with regards to the anticoagulation for her. So,
okay. Let's turn to the day before discharge, and there's been quite a lot of comments in the nurses' notes, and in fact they called another doctor, Dr. A.B. here, about her nausea and vomiting and chest pain. Would you like to tell me what you made of that? Well, how you assessed all that?
Well, she was very stressed at that time, and she was also grieving, and I put that down to those two factors basically that could be the cause of the pains as well. And she was given a lot of morphine, and at some stage she did refuse it, and I think that that was a factor that actually caused the nausea and vomiting. She also had it could be also due to her through her reflux, as well as it could be a recurrent pancreatitis. So we did do a lipase level on her, but that turned out to be normal.
During her admission, her blood pressure was a bit high. What did you think about management of that?
Yes, it was a bit high, but I put that down to stress.
Okay. All right, well, my final question relates to the time just before discharge, and you made some notes here. Do you think this lady was well prepared for discharge?
Well, she was very keen to go home at that time, and if you look into my notes, I did put the key issues there, and if I had a chance, I would have actually gone through with her and look into what would be her understanding with her current condition. But because she was in a grieving state, so I didn't have a chance. So what I did was I actually spoke to her JP, and as well as wrote a letter to the heart failure program with regards to these key issues from discharge. So, yeah.
Okay. What about the, I noticed during the admission that you had concerns about diuretic. What about ongoing diuretic treatment of this lady?
Well, she had a bad reaction with the with diuretics in the past. So she took thiazide and she had hyponatremia, and when she took furosemide, she felt very dizzy with this medication. Her chest was very clear at that time, so I just waited for the renal function test to come back.
Okay. But you've got those back now, and they're pretty normal. So what other sort of diuretic thoughts do you have? It's a tricky one. Okay. All right, we might stop there and leave enough time for feedback.